Jenny Loonsman, who is a PhD in microbiology and spent many years working in applied microbiology. In her last position to joining the U.S. National Institute for Occupational Safety and Health, I think Arif mentioned the NIOSH Foresight Fridays as well. So we have a few NIOSH mentions in her position. In her last position prior to that, she was the science lead for the Laboratory Information Management System implementation in the U.S. Centers for Disease Control and Prevention, infectious disease laboratories. Since 2011, she's been with NIOSH as a co-lead of an initiative to include and use patient work information in electronic health records. So people know this is one of our main thrusts of the ODAP work as well. And she works in the surveillance branch for the respiratory health division. So please welcome Jenny Loonsman.
Thank you for that introduction. Hi, I'm pleased to present to you today, and I'm going to start by introducing you to the NIOSH mission, which is to develop new knowledge in the field of occupational safety and health and to transfer that knowledge into practice. The NIOSH mission is to develop new knowledge in the field of occupational safety and health and to transfer that knowledge into practice. And in order to address this mission, since 2006, NIOSH has been working to improve the use of health IT systems. Health IT systems provide an opportunity to couple work information with clinical information. If that work information is standardized, then it's computable and supports data analyses. So it would be much easier for public health to identify work-related health risks, track disease transmission in the workplace, and monitor trends in work-related illnesses and injuries. Computable work information would also assist in clinical care by facilitating access to knowledge about work and health. Access to standardized work information would also help clinicians recognize new work-related conditions or new relationships between work and health. And rapidly identifying a work-related illness or injury could lead to implementation of preventive measures sooner and protect more workers. Today, I'm going to tell you about the path we've taken to get to the future collection and use of standardized work information in health IT systems in the U.S., with a focus on electronic health records, or EHRs. So first things first, the information about a person's work cannot be used or useful if the IT system cannot collect it. Since collecting and using standardized work information is a really new idea in health IT, we needed to determine what the IT system requirements would be. That means we had to decide what the most important data elements are, how to model the relationships among them, and what the possible standardized entries could be. We also had to think about the data needed to be managed by the health IT system, and what were the ways they could be collected, how they needed to be maintained, when and where they needed to be easily accessed or shown to a system user or included in a data sharing transaction, how they might be analyzed, and what the needs were as far as security in the EHRs. To this last point, we've advocated that the information is a part of the medical record and therefore to be secured and kept private, similarly to other clinical information. In order to figure out the health IT system requirements, we started with user stories. Our user stories are real or anticipated clinical scenarios that benefit from access to standardized work information in the health IT system. We wanted to make sure the data elements and other requirements met the needs of clinical care as well as public health. So for every data element, we considered examples such as the one shown here. In this story, a work schedule entry of rotating shift with nights or evenings is used to assist in care of a working patient with diabetes or a population of patients with diabetes who are having challenges managing their A1C level. Here are some examples of using job occupation and job industry to improve the health of patient populations. These first examples came from a pilot in which current job occupation was collected as text, exported with demographic data, and shared with the state public health department. The state agency collaborated with NIOSH to convert the occupation text to standardized coded data and analyzed it with the demographic data. Many of the patients spoke Portuguese, and the women tended to be maids and housekeepers, and the men tended to be construction and maintenance painters. So these educational materials mentioned in the first two boxes here were made available in Portuguese on the clinic's intranet site. The care providers of the clinic felt that this was great because they now had a way to help these patients stay healthy. Exporting the data to standardize it later is, of course, not a sustainable or scalable way of doing things. And the data also need to be analyzable with the clinical data. So this way of capturing it was not a long-term solution. Since then, we've developed a way to collect standardized industry and occupation terms, and I'll show you that shortly. My last example is an example of the desired data flow for public health case reporting and response. Here we have a worker who is grinding an engineered stone countertop. He's experiencing breathing problems and goes to see his healthcare provider. Because of his occupation, he's tested for silicosis, a severe, progressive, and disabling lung disease that's an emerging issue in the U.S. among engineered stone countertop workers. When this person's care provider enters the diagnosis of silicosis into their EHR, in the future, the public health electronic case reporting system will automatically send the information about the case to the state public health agency according to the laws in that state. The state agency can set up an electronic report response to give information back to the clinician. That response might be an alert to watch for cases among younger workers, for example, since many of those with silicosis that's associated with engineered stone are less than 50 years old. The state agency also sends the de-identified case information to CDC, which you see in the bottom right-hand corner here, since silicosis is a nationally notifiable condition per agreement between the states and CDC. The state agency investigates the cases it receives and may reach out to the employer for site visits or to provide guidance on improvements for interventions to prevent further cases in their workforce. To date, 19 cases of silicosis have been identified among stone fabrication workers in 4 states, and an unknown number of workers remain undiagnosed or unreported to public health. Having this electronic system in place is anticipated to reveal many more cases. Building from these user stories for patient care, population health, and public health, we developed a set of informatics products called Occupational Data for Health, or ODH. The audience for ODH is EHR and other health IT system developers who can make the collection and use of work information possible. ODH describes requirements for work information in health IT systems and lays out how the data, lays out what the data are and how they can and should be managed in the system. It's built as a framework and can be adapted in the system to address specific user needs. The data are almost all standardized and therefore computable to support analyses and other uses. And ODH is really only intended for use in health IT systems. ODH does not prescribe the scope of work information that an organization might want to use, how or when the patient or their representative enters the information, or how the organization might choose to fit it into their workflow. The first step in creating ODH was identifying and organizing the data elements, which resulted in these 6 topics. Along with that, we created value sets of the standardized entries for most of the data elements. This last topic here, that's highlighted in blue, is a little different in that it describes data elements that are not about the patient, but they're about the work of a household member of a child. This information in a child's record could be used to assist in determining the cause of a child's illness or injury, or better yet, to discuss and prevent inadvertent take-home exposures to health hazards that may unintentionally be brought home from work by an adult. The job topic is at the heart of ODH. We use the word job as a time-bound concept when a person works for an employer or organization doing a specific kind of work. A system requirement is that steps need to be taken to make sure the data for each job are associated with one another and not mixed and matched with data from other jobs. This is most notable in accommodating more than one job at a time. since many people work 2 jobs or more. The critical data elements of this topic are job occupation and job industry. While many people think of occupation as important, industry is also important. For example, an administrative assistant working in the banking industry may have different exposure risks than an administrative assistant working in the chemical manufacturing industry. The importance of industry has also become evident in the current pandemic response. We strongly suggest that current job occupation, job industry, and employer name and address be captured, and that over time, a history of jobs is built and retained. These are also the key elements for public health case reporting. There are additional ODH job elements that a healthcare organization might choose to collect and use. For example, work classification characterizes the arrangement between the person and the employer. For example, it would be used to record that a person is self-employed, which comes with different health challenges and concerns. Work classification also is used to identify voluntary work in emergency or disaster response, and to distinguish between work in the armed forces versus a civilian job that happens to be in a military branch of government. Supervisory level can also be an indicator of different risks for some jobs. This value set includes pay grades for U.S. military service, which is interpretable across branches and can help to distinguish between officer and enlisted service member occupations. Some organizations might want to collect and use additional job elements. For example, if someone is involved in diabetes management, they might want work schedule, as we have already discussed. We did not define value sets for job duties and occupational hazards in ODH, but it is something we want to look at in the future. The usual work topic refers to a person's longest held type of work. It is not bound by the concept of job and can span many jobs. The usual work topic includes a simpler group of data elements. While we focus on usual occupation and usual industry, knowing the start date and duration can also be beneficial, particularly when considering cancer and other conditions with a long latency or cumulative exposure risks. Usual work information is also helpful when a full work history has not been collected. Wrapping up ODH topics, employment status consists of a single data element with 3 possible entries that are the same as those used for employment status by the U.S. Department of Labor. Retirement date is self-defined, and ODH recognizes that some people retire more than once. In particular, many people retire from the armed services and then go on to retire from a civilian career as well. Working in a combat zone carries unique health risks, and both civilians and service members can work in these zones. Combat zone work proved to be complicated to model. It does not necessarily align with a single job, so we kept it separate from job information. As we explored how to represent it, we decided that collecting only the time period was the most straightforward choice. Having this information could prompt a conversation between the care provider and the patient to explore concerns and consider appropriate referrals, such as to care or benefits from the U.S. Department of Veterans Affairs, or VA. So occupation and industry are the key concepts about a person's work. However, it can be difficult to collect them as standardized and therefore computable entries. There are thousands of occupations and industries and multiple ways to identify many of those. Currently, some EHRs support collection of job occupation as free text. As we've discussed, this presents challenges. For example, if cowboy was entered as free text, when you wanted to analyze the information, you would not know if this individual is an entertainer or a ranch hand. So we knew we wanted a way for the person to select a fully useful term and to validate the information themselves. In developing the ODH occupation and industry value sets, we looked for sources that would support smart word searches with recognizable terms. The terms in the value set also needed to support individual conversations between the healthcare provider and the patient, as well as categorization for population health and public activities. So we were really setting up a totally new and different way to collect the information compared to a person entering text that would later be standardized through a classification coding process. We devised the ODH value sets of possible entries for occupation and industry using classification systems that have associated indexed or lay terms. The occupation value set includes lay searchable titles that are associated with the ONET Standard Occupation Classification System, or ONET SOC. ONET is an online service of the U.S. Department of Labor, which can be searched to find information about the knowledge, skills, and abilities required for an occupation. In thinking about ODH, the entry for our cowboy example in the EHR record using the ODH value set would show a combination of the lay title, cowboy, as shown here on the bottom, plus the classification. We did something similar for industry using the North American Industry Classification System, sometimes called NAICS, and the index titles for NAICS, which are also lay terms. The ODH occupation and industry value sets are very large and not amenable to a simple drop-down for selection. In addition, people need to understand what it means to enter occupation and industry terms. So we also looked at how to use computer system capabilities to help collect them. Through a series of usability testing prototypes, we explored how to collect occupation and industry, as well as the rest of the ODH concepts. This is a screenshot from our final prototype showing one of the screens for jobs. In this example, someone decided to search for the occupation cowboy and then can see two possible classifications. When they click on either one of these, they see a description and specific terms from which to select. The final entry would include both the specific occupation or lay term and the general occupation or classification, as I showed in the previous slide. In testing the prototypes, we also determined that how you ask the question matters. As simple as this may be, it wasn't until we started framing the questions on screen this way that people understood what we were asking them to search for and enter. So for industry, on screen, a person would see my company's primary business activity is. And for occupation, they would see, I can't see the screen. They would see I work as a or an. The prototypes for this project were strictly for testing and demonstration, since EHRs will have their own system set up for collecting data. So what we learned from the prototypes is described in a guide for EHR system developers. Additional EHR system requirements about how to manage the ODH data elements are outlined in an informative HL7 publication called a functional profile. HL7 is one of the two main international health IT standards development organizations. This functional profile describes helpful software features about collecting, maintaining, viewing, sharing, analyzing, and securing the ODH data. The last part of ODH is a set of templates for including patient work information in interoperability standards. Each template listed here is modular by topic, and I'll mention that interoperability standards are for formatting data for sharing between systems. A template for ODH can be dropped in whole or by topic to add work information into interoperability standards for almost any purpose. ODH templates are available in the three main types of interoperability standard formats for health IT systems. The newest and most rapidly gaining in popularity is FHIR, which stands for Fast Healthcare Interoperability Resources. Clinical Document Architecture, or CDA, is also frequently used to share clinical information. And the V2 messaging standard is most often used to share laboratory information and for some public health data sharing in the US. The interoperability standards or implementation guides shown here are many of the ones currently used to address data sharing needs, or also called use cases. They support both patient care and public health, and these all also include ODH topics as an option. For example, if you've heard of the CCD, that refers to the Continuity of Care document, and that's part of both the HL7 Consolidated CDA standard and the IHE Medical Summary Standard, both of which are used for many clinical care needs. In addition, the upcoming standards for electronic case reporting to public health include the ODH templates for job and for usual work. So to sum up what we've talked about so far, ODH is a modular and adaptable framework to help software developers incorporate useful patient work information in health IT systems. It includes a model of the data elements organized into topics with value sets to standardize the entries for most of the data, a guide and functional profile about how to set up systems to collect and use the data, and data sharing templates to meet interoperability or data sharing needs. So now that we have ODH, we're working harder than ever to leverage regulatory drivers for health IT system development and use in the United States. There are two agencies in the U.S. Department of Health and Human Services, or HHS, that are involved in this. First, the Office of the National Coordinator for Health IT, or ONC, sets the requirements for EHR certification. These requirements outline the data elements and interoperability standards that EHRs have to be able to accommodate. While we're making great progress in having key ODH data elements included in the upcoming certification requirements based on all of the work I just described. One of our next steps is to work toward incentivizing the actual collection and use of these data once the capabilities are available in the health IT systems. This could be done through the programs managed by the Centers for Medicare and Medicaid, or CMS. CMS is is the largest insurer in the United States, and it has been providing financial incentives for healthcare providers to use certified EHRs through its quality measure programs. We're considering collaborating with CMS to establish process measures that would become quality measures for the collection of key ODH data elements. We also plan to motivate the collection of these data by adding value through access to knowledge using clinical decision support tools and other aids. And with that, I will stop there.
Thanks so much, Jenny. And we absolutely have time for questions. I did want to state that, I first heard Jenny and Barbara speak about this at the Association for Occupational Environmental Clinics, which I sit on the board with, and Catherine Kirkland's our next speaker to talk about exposure codes. But Joel led out with this. Then Arif talked about the strategic foresight, and it's just important to know that vocabulary and vernacular is really important, and data is important. And Joel talked about and we all talk about how occupational illness is so underreported and underrecognized, right? When we are left with just WSIB data. So I wanted to show this, say that this all exists, right? This way of having your family physician through the electronic medical record system collect occupational data that then we can, if we had known how many people got COVID from work, we can do a lot. We can do a lot more with that when we know how many people are affected. How many people, Ron would talk about how many stone cutters are there in the world. So I just wanted to bring this to our attention to say, what the world looks like now elsewhere and what it could look like. So any questions for Jenny are more than welcome, but just, again, we're just sort of framing what the future could look like and what we need to do for occupational disease and illness prevention. Questions in the chat? I think I saw a hand.
Yes, it was me, Dorothy.
Hi, Dorothy. Go ahead.
Thanks very much for this. It reminded me that I'd heard about these records before, and I went and looked in my files and discovered that I'd responded when I was working for an organization in California in 2012. I responded to a NIOSH request for information about these things, about electronic health records. And one of the things that I brought up in that was, aside from what you just mentioned, Kimberly, but underreporting, was that many folks don't know how to take a good occupational health history. And so that was, I'm sort of curious about where that fits into the work that you're doing. The other thing that I'm informed by the work of Karen Messing around the difference between men's and women's jobs, and they can have the same job titles but be doing quite different work and therefore be facing quite different hazards. And so if you think of cleaners, that's a great example. So I'm wondering how you're sort of going to put a gender lens on this to make sure that that the work that women do that may have the same job title as guys is recognized as perhaps having different hazards.
So thank you for responding to the 2012 RFI. That was
a long time ago.
Information that was very, very helpful, the information that we got then. And we do understand the challenges with collecting a work history. One of the reasons that we want this to be patient-centered is that the patient can then verify that that's what I meant. And that's also why we spent so much time, several years, on determining how to ask those questions and what was a reasonable set of options for them. So some of the challenges with collecting an OH history was putting a boundary around it, which we did with this model. And if and then to the second part of your question about the differences between men and women's, there's sort of two ways I would think that that could be addressed. One is those very specific job titles. I suspect that women and men might pick something different in that specific index or lay title, although they might get categorized the same, which is what certainly public health normally works with those categories. So we'll have more information that way, coupled with their gender per the health records. The other thing is that the occupational health community can certainly provide information to the care providers that might separate that out in ways that are helpful. The nice thing about making this computable, by making it standardized, is that there are tools that the system could use to collect computable information. So one of the ways you could do that is something called CDS hooks. That's the technical term for how it's collected. But you could provide recommendations that are framed as if-then statements with triggers that would come out of the EHR, say, for example, if this person is working a rotating shift, then consider whether or not they're struggling to manage their diet. And that prompt could then also link to a place where they could get educational materials, for example. So there's a lot of ways to do this once the information starts being collected, and many, many ways it can be used.
And one other thing I raised in that letter, and it's something I, as a hygienist and ergonomist, I think about more perhaps than some of the folks who are docs or nurses, is that records like this give opportunities to do hazard surveillance rather than just health surveillance. And hazard surveillance is really much more along the lines of preventing things happening to people. So I'm wondering how I know that David Wegman was one of the people that talked about this probably at various points in time because he's written about it. There are other people who I know of where I'm just basically saying I'm not the only person who's raised this. So I'm curious about where you're at with that idea.
So in order to get the information, we have to be valuable to primary care. If we're not, then this isn't going to happen. So we were very much focused on first being valuable to primary care and what was really the critical minimum data that we needed to get. And so we focused on occupation and industry, knowing that that can be used by the occupational community to understand and dive into the risks and exposures, for example. And in the future, when this is collected and people are appreciating the value of it, then shifting to that kind of surveillance would be much, much easier. But certainly any of the information in the record with the proper interoperability standards and permissions can be shared to support the occupational health community in looking into those things.
Thanks. And if Carrie's still working on this, say hi to her for me.
I will. I have not talked to her in a long time, but I will definitely say hi to her.
Thank you.
I don't want to miss one other question from Lisa that we missed Lisa last time around. My apologies, Lisa. So she's asking if it would be, and it kind of follows along to Dorothy's comments around the hygiene and exposure piece. And again, we look to NIOSH in the hygiene world for methodology on exposure assessment. So looking to them for this medical record and data collection is just the path forward. So would it make sense for de-identified data from workplaces on what chemical ingredients are found as they relate to potential diseases? For example, housekeeping is pretty much the same in long-term care homes as in hotels. Similarly, in automotive shops are similar to vehicle maintenance shops and municipal operations. Would it be valuable to have data on the types of carcinogens, mutagens, respiratory toxins, and reproductive hazards that are typically found in those environments to compare against what diseases are being?
Sure. I mean, that'd be a great use of the data as time goes on. We, you know, when I came to NIOSH and started realizing the depth and breadth of knowledge and research that happens in the occupational health community, I was a little stunned that it's not already applied more widely and known more widely. And so I think by having this information in an electronic health record and setting up that sharing capability with public health and really with the right permissions, researchers will also be able to access it. Then, you know, that should really support not only getting the data, but also informing care and prevention strategies. So I think that's certainly the future that we envision once this information is collected. Yeah, I think that's great.
Thanks so much, Jenny. And of course, you know, all of primary, secondary, and tertiary prevention are necessary to tackle, you know, illness prevention. And with data and evidence, you know, we need to build that. And there's so many steps for us between this and that, and I don't want to give people the impression, but also I do want to say that it's accessible and you've done so much work. So why are we not taking these best practices and implementing them internationally? So I really, really appreciate your time.
Sure.
I don't see any questions in the chat window, and if seeing none, I will move on to, I think you're sticking around for a tiny bit, and that would be great. And I know Barbara's here in case other questions pop up. Oh, another one from Lisa. We're not missing you, Lisa. That's not happening. Did you see partnerships with the private sector? Do you see partnerships with the private sector to provide this data?
So I'm not exactly sure what private sector would use the data in the ways that I'm thinking of in terms of collecting the data, but in terms of understanding the consequences and risks and prevention strategies, you know, on the flip side of it, yeah.
Great.
I'm not super versed in the relationship between employers and healthcare. We had a different subject matter expert on that, and she's no longer with us. But,
and I think Jenny's making the point, Lisa, that, you know, this is medical information, so not really the private sector wouldn't have access to it that we're looking for from the you know, from the ground. But it's the kind of how we would utilize it more than the output rather than the input. And I think I see another face or hand.
Yeah, sorry, it's Lisa. I was just, thank you for taking my questions, but it was just follow up. The products that are being used in the workplace are really privy for the workplace, but that data is publicly available data. It's just, you know, just need to aggregate it and share it in relationship to the workplace if the workplace is willing, or it can be de-identified and associated with sectors. So that's what I meant in terms of, you know, would you work with private sector organizations who collect that kind of data to potentially feed into your ODH system?
So studies like that could certainly be done. And if the data could be clearly defined and collected in a reasonable way or merged in a reasonable way, then absolutely. The tricky part with electronic health records is that as researchers, we're also used to having a wide array of information that we can pull from, and we can use spreadsheets and other tools. And you know, narrative doesn't boggle our minds, but narrative, for example, is really hard for a computer. It just doesn't lend itself to analyses. So while it is absolutely a future that I can envision, there's a lot of steps to get from the way studies are, data is collected and interpreted and the information is provided. All those steps need to be done. Does that make sense?
Yeah, strategic foresight from Marie. So yeah, thank you for that. You're thinking ahead, Lisa. So yeah, and I do just want to make a plea to all the workers and the unions and the labor organizations that are with us today that you know, it's asking your physicians, you know, if they're collecting data on what you do at work, and you know, when it's part of your this is, you know, the step beyond that, and we know we need to have physician education, clinician education. We know we need to have proper occupational health histories, as Dorothy put, but you know, then it gets to these mechanisms, and then all the worlds collide and meet to get us where we need to go. So you know, it's important that it might seem like, you know, sky high, but it's really important that people are aware that this, you know, can exist, does exist, and we need to ask for it. You know, so I just really appreciate it, Jenny, and I think we'll introduce Catherine now.
Thank you for the opportunity to talk with you.
Thanks. Cheers.